Picture this. Your heart suddenly feels like it's doing somersaults in your chest, a weird fluttering that makes you catch your breath.
Mm-hmm.
Maybe a split-second feeling of dizziness that makes the room tilt. Sound familiar at all?
It probably does to a lot of people.
Exactly. What if those fleeting, almost bizarre sensations weren't just random quirks, but tiny, rapid bursts of electrical activity within your very own heart?
Right.
We're not talking about something super rare here. This is about a surprisingly common event, something, dramatic that can happen to anyone, regardless of how healthy you might feel.
And today, we're going to plunge right into that world. The world of paroxysmal supraventricular tachycardia, or PSVT for short.
PSVT, got it.
Think of this as an in-depth exploration. We want to understand exactly what PSVT is, the many different ways it can show up, how doctors figure out what's going on,
Like the diagnosis part.
and the very latest, most effective ways to manage it, and maybe even stop it from happening in the first place. And importantly, our entire discussion today is built on the most up-to-date medical research.
And the key to this deep dive is this really comprehensive review article. It's like a condensed guide, isn't it? Bringing together the most crucial information, guidelines on diagnosing, treating PSVT.
Yeah, from a huge number of studies published between 1998 and 2023.
Well, it's a wide range.
It is. The researchers really dug deep, looking at, I think, thousands of articles to give us the most relevant and current picture.
So our goal today is pretty simple, really. We want to break down the complexities of PSVT, get rid of some of that confusing medical language, and pull out the essential knowledge. We want you to walk away with a clear and hopefully engaging understanding of this condition.
Absolutely. And before we dive deeper, we really want to express our sincere gratitude to London Heartbeat Z Academy in the UK. They've provided generous educational support for this discussion.
Sounds fantastic.
They offer a really great range of over 150 popular courses, so we definitely encourage you to explore what they have available.
Definitely worth checking out. And if you're keen to stay informed about discussions like this one, make sure to follow London Heartbeat's Z Academy on their social media channels.
Right.
You can find them on Facebook, Instagram, and YouTube for free regular updates.
Yeah.
You definitely won't want to miss out on the valuable insights they share.
Good advice.
Okay, so let's start to unpack this term. Supraventricular tachycardia, SVT. What does that actually mean?
Right. So SVTs are essentially fast heart rhythms. We call them tachyarrhythmias.
Tachy meaning fast.
Exactly. And they start in or travel through the upper parts of the heart, the atria, or this really important electrical hub called the atrioventricular node, or AV node for short.
Okay.
These fast rhythms mean the heart is beating at more than 100 beats per minute. And when we look at an electrocardiogram and ECG, they often show up as what we describe as narrow QRS complexes, typically less than or equal to 120 milliseconds.
So a rapid heartbeat starting upstairs in the heart, and it usually has a specific look on the ECG trace. And PSVT is a particular kind of SVT then.
Precisely. The key word is paroxysmal. That tells us it's episodic.
Comes and goes.
Right? It begins suddenly, and just as importantly, it stops abruptly. It's not usually a gradual thing.
Okay.
And within this larger category of PSVT, the most common types are atrioventricular nodal reentrant tachycardia, that's AVNRT.
AVNRT.
AV reentrant tachycardia, or AVRT.
AVRT.
And what we call focal atrial tachycardia, or just AT.
Got it. AVNRT, AVRT, and focal AT. Now, the review specifically mentioned that we won't be focusing too much on atrial flutter or sometimes atrial fibrillation, even though they technically fall under the SVT umbrella.
Yeah.
Why make that distinction?
Yeah, that's a good question. While they are related, they involve the upper chambers. They can cause a fast heart rate, atrial flutter, and atrial fibrillation, or AFib, tend to have different underlying causes.
Different mechanisms.
Different mechanisms, and therefore they need different approaches to how they're managed. Completely different risk factors and treatment strategies, really. And similarly, there are some rare forms of SVT, things like junctional ectopic tachycardia, nodoventricular tachycardia, nodofascicular tachycardia. But, to keep our focus sharp and clear today, this deep dive will concentrate on those main 3 PSVT subtypes, AVNRT, AVRT, and focal AT.
That makes perfect sense. Focus on the big ones. So how common is PSVT in the United States? Are we talking about a lot of people?
Well, estimates based on looking back at large collections of patient data, these big clinical databases, they suggest that in the U.S., somewhere between maybe 168 and 332 people out of every 100,000 experience PSVT.
Okay, so not incredibly rare then.
No, not at all. And interestingly, PSVT often occurs alongside other health conditions. It doesn't always happen in isolation.
Oh, really? Like what sort of other conditions?
The review points out several major health issues that are often seen in people with PSVT. Chronic lung disease, like COPD, is present in about 15.7% of cases. Diabetes in about 12.5%, heart failure in 8.4%, cerebrovascular disease that affects blood vessels in the brain in 7.8%, and peripheral vascular disease affecting blood vessels outside the heart and brain in about 7.6% of folks with PSVT. So it's interesting to note how frequently PSVT overlaps with these other conditions.
That's a significant connection with other health problems. It's also fascinating, you mentioned the review says this, that while the medications used to treat PSVT acutely, like in the moment, haven't changed a whole lot over the last couple of decades.
Right. The pharmacologic therapy is pretty similar.
But there have been some real breakthroughs in other aspects of dealing with this condition.
Absolutely. We've seen really impressive progress in how we monitor the heart, picking up these episodes, and especially in the development of what we call ablation therapies.
Ablation. We'll definitely get into that later.
We will. These advancements have given us much more precise ways to diagnose PSVT and, crucially, offer treatment options that can potentially cure the condition for patients, which is a huge step beyond just managing symptoms.
A cure. That's a big deal. So PSVT isn't just something that affects adults, is it? The review mentions both children and adults.
That's right. It occurs in both pediatric and adult populations. While we don't have an exact figure for how common it is in children, estimates suggest it affects somewhere between 1 and 4 children out of every 1,000.
Okay.
And one study that looked at a large insurance database actually found that the overall rate of SVT, and this is whether or not it caused noticeable symptoms in kids up to 15 years old, was about 1.03 cases per 1,000 patient years. So that gives us a clearer picture of the frequency in younger individuals.
That gives us a better idea of the numbers in kids. And what about the general demographics of PSVT across all ages? Who is more likely to experience it?
Okay, so across the board, the majority of individuals with PSVT are actually female. They make up about 67.5% of cases.
Interesting. More common in women.
Yes. And when we look at age, roughly half, around 50.3%, fall within the 45 to 64-year age range,
Right.
middle age. It's also worth noting that the likelihood of experiencing PSVT tends to increase as people get older. So it's more common in middle-aged women, and the risk seems to go up as we age.
Now, the term lone PSVT came up in the review. What exactly does that mean? Is that like PSVT happening on its own?
Pretty much, yeah. Lone PSVT refers to instances where individuals experience PSVT, but they don't have any other underlying cardiovascular conditions.
Okay, so no high blood pressure, no coronary artery disease.
Exactly, none of that. No heart failure, cardiomyopathy, valve problems, AFib, sick sinus syndrome. And interestingly, one observational study found that lone PSVT accounts for a significant portion of new PSVT cases, about 39% in their study of over 1,700 patients.
Wow, almost 40%.
Yeah, it shows that PSVT isn't always linked to pre-existing heart issues. It can happen in otherwise healthy hearts.
That's a pretty significant chunk. And are there any noticeable differences between people who have this lone PSVT and those who have PSVT, along with other heart problems?
Yes, there are some interesting distinctions. Patients with lone PSVT tend to be younger. The average age in that study was 37, compared to 69 for those with PSVT and other cardiovascular diseases.
Big difference.
Yeah. And they also tend to have a faster average heart rate when they're having an episode around 186 beats per minute versus 155.
Even faster. Wow.
Yeah. However, the specific factors that might lead to lone PSVT, the risk factors, they aren't very well understood at this point. It seems like even in otherwise healthy, younger individuals, these episodes can occur, and the heart can race quite rapidly.
Okay, so younger people with no other obvious heart issues can still get these episodes, and their heart can beat even faster during them. Let's switch gears now and talk about what's actually going on electrically in the heart to cause these rapid rhythms. We're talking about the heart's basic electrical system, right?
Exactly. Under normal circumstances, the heart's electrical activity begins in a special group of cells called the sinoatrial node, or SA node, often called the heart's natural pacemaker.
Right, the boss.
Kind of, yeah. From there, the electrical signal spreads through the atria, the upper chambers, causing them to contract and pump blood down into the ventricles.
Okay.
The signal then reaches the atrioventricular, or AV node. Think of the AV node as a gatekeeper. It briefly pauses the signal.
A little delay.
A necessary delay, yeah. Before sending it down through his Purkinje system, a network of specialized fibers, which then tells the ventricles, the heart's main pumping chambers, to contract and send blood out to the body.
Got it.
This carefully coordinated sequence, which is shown nicely in Figure 1A of the review, ensures that blood flows efficiently through the heart chambers in the right order.
So that's the normal, smooth electrical flow. How does that get disrupted to cause an arrhythmia like PSVT? What makes it go haywire?
Well, the review highlights three main ways this normal process can be disrupted. The first is called enhanced automaticity.
Automaticity.
Yeah.
Like firing on its own.
Exactly. Either the heart's natural pacemaker cells, the SA node, start firing electrical signals too quickly, or sometimes even cells that aren't normally pacemakers gain the ability to spontaneously generate these signals when they shouldn't.
Okay. Rogue signals.
Kind of. The second mechanism is triggered activity. This involves abnormal electrical oscillations, little extra electrical blips that happen after a normal heartbeat, and these can then trigger extra premature beats.
Okay.
But the third mechanism, and this is the one that plays the most significant role in the common forms of PSVT we're focusing on, is reentry.
Reentry. That sounds like the electrical signal gets caught in the loop somehow.
That's a perfect way to think about it. Reentry, which is illustrated conceptually in Figure 2, happens when an electrical impulse travels in a circle or a loop within the heart tissue instead of just going straight through.
Right.
This can occur when there are different electrical pathways in the heart muscle that have varying properties. For instance, one pathway might conduct the electrical signal faster than another adjacent pathway.
Like a fast lane and a slow lane next to each other.
Exactly. Or one might take longer to recover after conducting an impulse, meaning it's ready to conduct again sooner or later than its neighbor. This difference allows the signal to basically chase its own tail, keep circulating in a continuous loop, and that drives the very rapid heart rate we see in PSVT.
Okay, so instead of a straightforward one-way flow of electricity, it gets stuck going around and around in a loop because of these different pathway characteristics.
Yeah.
And we mentioned earlier that AVNRT is the most common type of PSVT. What's the specific reentry mechanism involved there?
Right. Atrioventricular nodal reentrant tachycardia, AVNRT. This accounts for around 56% of PSVT cases that eventually get treated with catheter ablation, so it's the most common one we see in the lab.
Okay.
In the typical form of AVNRT, there are essentially two pathways within or very close to the AV node itself, a functionally defined slow pathway and a fast pathway.
Two paths right near the gatekeeper.
Exactly. During AVNRT, the electrical impulse typically travels down the slow pathway, which anatomically is usually located towards the bottom of the AV node, near the tricuspid valve and the opening of the coronary sinus, as shown in Figure 1B. It then finds its way back up to the atria using the fast pathway.
Oh, okay.
So it's a tight loop right there within the AV nodal region itself. Slow down, fast back up.
So it takes a slow lane down, and then, because the fast lane has recovered, it can zip back up the fast lane, creating that continuous loop within the AV node area. What does that look like on an ECG? Is it distinctive?
It often is, because the electrical impulse is traveling back upwards towards the atria almost at the same time as it's going downwards to activate the ventricle.
Happening almost simultaneously.
Right. The retrograde P wave, which represents the electrical activity of the atria contracting due to that upward signal, often gets buried within or occurs very close to the QRS complex, which represents the ventricles contracting.
So they overlap.
They overlap, making it difficult to see the P wave clearly on the ECG. And this is why AVNRT is sometimes referred to as a no RP tachycardia or a short RP tachycardia, because the RP interval, the time between the ventricular signal, or war wave, and the subsequent atrial signal, P wave, is very short or essentially non-existent visually.
That makes sense. The signals are happening so close together in time that they basically merge on the tracing. Now, what about AVRT? That was the second most common type preferred for ablation. How does that mechanism differ? Is it still a loop near the AV node?
No, atrioventricular reentrant tachycardia, or AVRT, which makes up about 27% of PSVT cases referred for ablation, involves a different kind of loop. In AVRT, the reentry circuit involves an accessory pathway.
Accessory pathway, like an extra electrical connection.
Exactly. It's also called a bypass tract. These pathways, illustrated in Figure 1C, are abnormal electrical connections that form during development, bridging the gap between the atria and the ventricles. Essentially, an extra electrical wire that shouldn't normally be there, crossing the insulating AV ring.
So it bypasses the normal AV node gatekeeper.
It can, yes. They're present from birth in roughly 1 out of every 1,500 individuals, so they're congenital. Instead of just the normal AV node connection providing the only route down, there's this extra pathway that can become part of a rapid reentry circuit.
Okay, so instead of just the normal AV node connection, there's this extra pathway, an abnormal electrical wire that could be part of this rapid circuit. And the review mentioned that AVRT is slightly more common in men, unlike AVNRT, which was more common in women.
That's a subtle but interesting difference, yeah. AVRT is a bit more prevalent in men. About 54.6% of cases occur in males, whereas AVNRT, as we said, has that female predominance. Now, there are 2 main ways the electrical impulse can travel in an AVRT circuit, depending on which way it goes down and which way it comes back up, using the accessory pathway.
Okay, tell me about those 2 ways.
The first, and more common, is called orthodromic AVRT. Ortho meaning correct or straight. In this scenario, the electrical impulse travels down the normal route through the AV node and the His-Purkinje system to the ventricles, triggering them to contract.
So far, so good.
Right. But then, instead of stopping there, the impulse travels back up to the atria through the accessory pathway, completing the reentry loop that way.
Ah, so the accessory pathway is the return route.
Exactly. And because the ventricles are activated through the normal His-Purkinje system, the QRS complex on the ECG is usually narrow, just like in normal rhythm or AVNRT, unless there's some other conduction delay or block further down in the system. So it's the normal way down, the extra pathway back up.
Okay, down the normal path, up the extra path, typically leading to a narrow QRS on the ECG. What about the other direction then?
That's antidromic AVRT. Anti meaning against or opposite.
Right.
In this case, the electrical impulse takes the side road first. It travels down to the ventricles through the accessory pathway, bypassing the AV node initially.
Okay, using the shortcut down.
Yeah. This leads to a different, slower pattern of ventricular activation, but it's not using the rapid His-Purkinje system. And this results in a wide QRS complex on the ECG, typically greater than 120 milliseconds.
Wider QRS. That can sometimes look like other things, can't it?
It absolutely can. In fact, it can sometimes look very similar to ventricular tachycardia, which originates in the ventricles and is generally more serious, especially if the accessory pathway inserts into a particular area of the ventricle.
Okay.
So after activating the ventricles via the accessory pathway, the impulse then travels back up to the atria through the normal route, the His-Purkinje system, and the AV node, completing the loop in the opposite direction compared to orthodromic.
So down the extra path, up the normal path, leading to a wide QRS that can sometimes even mimic a more serious ventricular rhythm.
Wow.
Now, the term Wolff-Parkinson-White, or WPW pattern, came up in relation to these accessory pathways. What's that all about?
Right. So when there's antegrade or forward conduction through an accessory pathway during the heart's normal rhythm, sinus rhythm.
So when you're not having the tachycardia.
Exactly. On the baseline ECG, this forward conduction down the accessory pathway can create some distinctive features. One is a slurred upstroke of the QRS complex, which we call a delta wave.
The delta wave.
This happens because the ventricles start to depolarize or become electrically activated a little earlier than they normally would via the AV node due to that faster shortcut conduction through the accessory pathway. This early activation is known as ventricular pre-excitation.
Pre-excitation makes sense.
The other finding is a short PR segment on the ECG. The PR segment reflects the time it takes for the signal to get from the atria to the ventricles, including that normal AV node delay. Since the accessory pathway bypasses this delay,
the PR interval gets shorter.
Exactly. So when a patient has both this WPW pattern, the delta wave, and short PR on their baseline ECG, and they experience symptomatic SVT, usually AVRT, they are diagnosed with Wolff-Parkinson-White syndrome.
Okay. So the pattern on the ECG plus the actual episodes of rapid heart rate equals the syndrome.
You got it. The pattern itself isn't the syndrome. You need the symptoms, too.
But what if someone has the extra pathway, but doesn't show that WPW pattern on their resting ECG? Is that possible? Can it be hidden
Yes, that can definitely happen if they have what's called a concealed accessory pathway.
Concealed.
These pathways are still capable of conducting electrical impulses, but only in the retrograde direction, that is, from the ventricles back up to the atria. They can't conduct forward from atria to ventricles.
So they only work in reverse.
Pretty much. So during normal sinus rhythm, the electrical impulse only travels down the AV node to the ventricles, the normal way. It doesn't use the accessory pathway at all for forward conduction.
Right.
Because of this, you don't see the characteristic delta wave or short PR interval on the resting ECG. The pre-excitation isn't visible.
But the pathway is still there.
It's still there. And even though they're hidden on the normal ECG, these concealed pathways can still participate in orthodromic AVRT, providing that return route for the reentry circuit to form. They just can't cause antidromic AVRT or the WPW pattern.
Interesting. So you can have the extra electrical wire without it always being obvious on the standard ECG. The review also mentioned a potential risk associated with the WPW pattern itself, even without symptoms yet.
Yes, that's an important point. Patients who show a WPW pattern on their ECG, even if they haven't had documented symptomatic SVT, have a slightly increased risk of sudden cardiac death.
Why is that?
It's primarily due to the potential for very rapid conduction down the accessory pathway if they were to develop atrial fibrillation. In AFib, the atria beat chaotically and extremely fast. If those rapid signals conduct down the accessory pathway without the usual filtering effect of the AV node,
The ventricles could be driven way too fast.
exactly, potentially leading to ventricular fibrillation, which is cardiac arrest. The estimated incidence of sudden death in people with a WPW pattern is around 2.4 cases per 1,000 person years. It's not huge, but it's a real risk. Because of this potential risk, it's generally recommended that individuals who have a WPW pattern identified on their ECG should be referred to a cardiologist for further evaluation and risk stratification.
Makes sense.
The cardiologist can then assess their individual risk factors, things like the pathway's conduction properties, and determine the most appropriate management strategy, which might include further testing or even preventive treatment like ablation.
Better to identify and manage that potential risk early. Okay, now the third common type of PSVT we mentioned was focal atrial tachycardia, or AT. How does that differ in its origin from the reentrant tachycardias, EVNRT and AVRT we've been discussing?
Right. Focal atrial tachycardia, which accounts for about 17% of PSVT cases referred for ablation and is shown in Figure 1D, isn't typically caused by a big reentry circuit involving the AV node or an accessory pathway.
So not a loop between chambers or around the AV node.
No. Instead, it originates from a specific localized area, a single focus or spot within one of the atria. Think of it like a small area of the atrial muscle that starts firing off electrical signals way too rapidly and independently, basically hijacking the heart's rhythm from the SA node.
Like a misfiring spark plug in one of the atria that suddenly starts firing too fast and takes control.
That's a pretty good analogy, actually. The prevalence of focal AT tends to increase as people age, and it can be triggered by those other mechanisms we mentioned earlier. Enhanced automaticity, triggered activity within the atrial cells, or sometimes even a tiny reentry circuit that's confined just to the atrial tissue itself, especially in atria that are diseased or have undergone structural changes over time.
Okay, so it's like a hot spot in the atrium acting up. What does that usually look like on the ECG?
Focal AT typically presents with P waves, remember. Those represent atrial contraction that look different in their shape or direction, their morphology, compared to the P waves you see during the normal sinus rhythm originating from the SA node.
So you can tell they're coming from somewhere else.
Often, yes. However, if the abnormal focus happens to be located very close to the SA node, the P waves might actually look quite similar to normal sinus P waves, which can make it trickier.
Okay.
And at higher heart rates, especially if the electrical impulse from the atria is conducted down to the ventricles in a one-to-one fashion with each beat, it can sometimes be challenging to clearly identify the P waves on the ECG because they might get buried in the preceding T wave or occur very close to the QRS complex.
So sometimes you can see distinct abnormal P waves that give you a clue it's atrial tachycardia. But at faster rates, they might be harder to pick out clearly. How can you tell the difference between focal AT and something like atrial flutter, which also involves the atria beating rapidly?
That's a key distinction electrocardiographically. The key difference often lies in what the baseline of the ECG looks like between the P waves or flutter waves. In focal AT, you'll typically see discrete individual P waves with short periods of electrical silence, what we call isoelectric segments in between them.
Like a flat line between the bumps.
Exactly. It's like a series of distinct blips on the screen with a flat baseline in between. In contrast, atrial flutter usually has a more continuous, rapid, undulating baseline on the ECG. There's no flat line.
Right, the classic sawtooth pattern.
Precisely. Often described as a sawtooth pattern without those clear, flat isoelectric segments between the flutter waves. So discrete P waves point more towards focal AT, while a continuous undulating wave suggests flutter.
That's a really helpful visual distinction to keep in mind when looking at an ECG strip. The review also briefly mentioned multifocal AT. Is that just like focal AT but from more than one spot?
Essentially, yes. Multifocal atrial tachycardia, or MAT, is a less common type of atrial tachycardia that's often associated with significant underlying lung diseases like severe COPD or pulmonary embolism.
Ah, linked to lung problems.
Often, yes. What distinguishes it from focal AT is that on the ECG, you'll see at least 3 different shapes or morphologies of P waves within the same strip. This indicates that the rapid rhythm is originating from multiple different locations, multiple foci within the atria.
Okay, not just one misfiring spot, but several.
Right. And additionally, the rhythm in multifocal AT is typically irregularly irregular, meaning there's no consistent pattern to the timing of the heartbeats, unlike the usually regular rhythm seen in most focal AT.
Okay, so focal AT. Usually one abnormal P wave shape, regular rhythm, one spot. Multifocal AT, multiple different P wave shapes, irregular rhythm, often linked to lung issues.
Got it. Let's move on now to how PSVT actually feels to someone who's experiencing it. What are the common signs and symptoms that people report?
Patients who experience PSVT often report a very sudden, abrupt onset of symptoms. It hits them out of the blue.
Like flipping a switch.
Exactly. The most common symptom by far is palpitations, that sensation of your heart racing, pounding, fluttering, or beating irregularly. That occurs in about 86% of cases.
The vast majority, then.
Yeah. Other frequently reported symptoms include chest discomfort, which can feel like pressure or tightness that's in around 47% of patients, shortness of breath at about 38%, and lightheadedness or dizziness reported by roughly 19% of individuals. So a heart that feels like it's racing or fluttering, tightness in the chest, feeling out of breath, and a bit dizzy, that sounds quite unsettling and can be understandably alarming for someone.
Oh, absolutely. It can be very frightening, especially the first time it happens.
Does the severity of these symptoms tend to vary much from person to person or episode to episode?
Yes. The intensity of symptoms can definitely depend on several factors. One key factor is how fast the heart rate actually gets during the episode of PSVT. Higher rates often cause more symptoms.
Makes sense.
Another factor is whether the person has any underlying coronary artery disease. If they do, the rapid heart rate might cause more significant chest pain or shortness of breath because the heart muscle isn't getting enough oxygen. It's also important to note, though, that even if someone experiences ST depressions on their ECG during an SVT episode, which can sometimes indicate a lack of oxygen to the heart muscle, or if they have slightly elevated levels of troponin, which is a marker of heart muscle stress, especially if they are young and otherwise at low risk for heart disease. It doesn't usually mean they have significant underlying coronary artery disease.
Oh, okay. So those findings don't automatically mean blocked arteries in this context.
Not necessarily. Those changes can sometimes occur just due to the stress of the very rapid heart rate itself on the heart muscle, the supply-demand mismatch.
That's reassuring to know, as those kinds of findings on a test can certainly raise concerns about more serious heart problems. What other complications, beyond just the immediate symptoms, can sometimes arise from PSVT?
Well, in individuals who already have underlying heart failure, an episode of PSVT can actually worsen their condition significantly. It can even lead to acute pulmonary edema, which is a buildup of fluid in the lungs, making it very difficult to breathe.
So it can really tip someone with existing heart failure over the edge.
It can. Interestingly, while syncope, fainting, or passing out can sometimes occur around the time of a PSVT episode, it's relatively rare for it to be a direct result of the rapid heart rate itself causing insufficient blood flow to the brain.
Oh. So what causes the fainting then?
It's more likely to be what we call a vagally mediated response. Basically, the sudden onset of the fast rhythm, or sometimes its abrupt termination, can trigger a strong reflex involving the vagus nerve. This reflex can lead to a sudden drop in both blood pressure and heart rate, causing the person to faint. It's more of a reflex reaction to the event.
Ah, Okay. So while the very fast heart rate is the primary electrical issue, it can have these knock-on effects, especially for those with pre-existing heart problems, and can trigger fainting through reflexes. And the episodes of PSVT themselves, do they always require medical intervention to stop, or can they sometimes just stop on their own?
No, they don't always need intervention. Symptomatic PSVT can sometimes terminate spontaneously. The rapid heart rhythm can just abruptly stop on its own just as suddenly as it started.
Right.
However, in many cases, especially if the symptoms are very bothersome or if the episode goes on for a long time, medical intervention is needed to restore a normal heart rhythm and alleviate the patient's symptoms.
Okay. Now, if someone is experiencing these kinds of symptoms, the sudden palpitations, dizziness, etc., what's the typical process that doctors go through to figure out if it's actually PSVT? What kind of evaluation or workup is usually done?
The evaluation for suspected PSVT usually begins, as with most things in medicine, with a thorough medical history.
Talking to the patient.
Absolutely critical. The doctor will ask detailed questions about the onset of the symptoms, how suddenly did they start, what triggers them, if anything, what was the timing and duration of the episodes, how frequent are they?
Getting the whole story.
Exactly. They'll also want to know about the patient's overall cardiovascular health history, any known heart conditions, previous tests, family history, and any other medical conditions they might have. Then there's the physical examination. But interestingly, if the patient doesn't have any underlying structural heart disease, the physical exam might actually be completely normal in between the episodes of rapid heart rate.
So the exam might not reveal much unless they're actually having an episode right then and there.
Often that's the case. So getting a good understanding of the patient's history, their description of the episodes is really crucial.
What about diagnostic tests then? I imagine the electrocardiogram, the ECG, is a key part of this.
Absolutely. A 12-lead ECG is the cornerstone, the gold standard for diagnosing PSVT. Ideally, you want to capture an ECG while the patient is actually experiencing the rapid heart rhythm.
Catch in the act.
Precisely. The pattern on the ECG during the tachycardia can often give very strong clues about the specific type of SVT that's occurring, whether it looks like AVNRT, AVRT, AT, etc. However, even an ECG that's taken after the episode has stopped, especially if it was terminated by a medical intervention like medication or cardioversion, can still provide valuable information. For example, it might show that underlying WPW pattern we talked about.
Okay. But what if the episodes are infrequent and short? It must be hard to catch one happening in the doctor's office.
It often is. That's where ambulatory cardiac monitoring comes in. There are several types of devices that patients can wear to try and capture those intermittent episodes that might not happen during an appointment.
Like Holter monitors.
Exactly. Holter monitors continuously record the heart's electrical activity, usually for 24 or 48 hours, sometimes longer now. Then there are external patch monitors that are smaller adhesive recorders that can be worn for up to several weeks.
Longer monitoring window.
Yes. There are also event monitors. With these, the patient typically activates the recording themselves when they feel symptoms starting. And for very infrequent but significant symptoms, there are even small implantable loop recorders, ILRs. These are tiny devices inserted just under the skin that can monitor the heart rhythm continuously for months or even years.
Wow, for years. So there's a range of monitoring options available depending on how often the symptoms occur and how long the episodes typically last. What about all those consumer wearable devices we see advertised, like smartwatches with ECG capabilities? Can they be helpful in diagnosing PSVT? Are they reliable enough?
That's a really hot topic right now, and an area of growing interest and ongoing research. But the current evidence on the reliability specifically for diagnosing PSVT is still somewhat limited. One study, for example, looked at how well these types of devices could detect SVT that was intentionally induced in patients during an electrophysiology lab study, a controlled setting. They found that the sensitivity, that is, how often the device correctly identified an episode of SVT, was actually quite poor for short episodes, like those lasting less than 15 seconds.
So they missed the short bursts.
They often did. However, the accuracy did improve significantly for longer episodes, those lasting over 60 seconds, when compared to a standard 12-lead ECG. So while they might pick up on more prolonged episodes, they may not be very reliable yet for catching those brief, fleeting bursts of PSVT.
So it sounds like they might be useful for longer events, but maybe aren't quite there yet for reliably diagnosing those shorter, more paroxysmal episodes. What about those direct-to-consumer devices that have actual leads you place on your body to record an ECG trace, like KardioMobile or similar things? Are they more accurate?
That's another area where we definitely need more research and data specifically on their diagnostic accuracy for PSVT compared to standard medical grade monitoring. It's a rapidly developing field, the technology is constantly improving, but rigorous validation studies are still needed for specific arrhythmias like PSVT.
Right.
Interestingly, though, looking beyond just consumer devices, artificial intelligence, AI, is starting to play an increasing role in the diagnosis and risk assessment of various heart rhythm problems.
AI in diagnosing heart rhythm problems. That sounds futuristic. How is that being used?
It's pretty fascinating. Researchers are using machine learning algorithms, basically training computers to analyze vast amounts of ECG data from thousands, even millions of people.
Looking for patterns humans might miss.
Exactly. By identifying subtle patterns in the electrical signals that might not be obvious to the human eye, these AI models are being trained to recognize characteristics that could indicate a higher risk of developing PSVT in the future, even in individuals whose baseline ECGs appear completely normal to us now.
Wow, prediction.
Potentially. One particular deep learning model, after being trained on a large data set of sinus rhythm ECGs, showed promising results. It demonstrated fairly good sensitivity and specificity in identifying patients who would later go on to develop PSVT. This could potentially lead to earlier identification and maybe even preventative strategies down the road.
That's incredible. Using AI to potentially predict future risk based on a routine ECG.
Okay, aside from the ECG and these various monitoring devices, are there any routine blood tests that are typically ordered for patients with suspected PSVT?
Typically, yes, doctors will order a set of routine blood tests. This might include a complete blood cell count, thyroid function tests, checking for an overactive or underactive thyroid, as that can sometimes trigger rhythm issues,
Right, thyroid problems.
and a basic metabolic panel, which looks at things like electrolyte levels, potassium, magnesium, calcium, and kidney function.
Do electrolyte imbalances often cause PSVT?
That's a good question. While we check them routinely, the review actually notes that a clear and well-established link between common electrolyte abnormalities and the development of PSVT hasn't been consistently found in the medical literature.
Oh, interesting.
So, while these tests are often done to get a general picture of the patient's health and rule out other contributing factors like thyroid disease, they may not be directly diagnostic for PSVT itself.
Okay. What about imaging the heart? Yes, a transthoracic echocardiogram, which is an ultrasound of the heart, is very commonly performed. This is to evaluate the structure and function of the heart muscle and valves and look for any underlying structural heart disease that might be contributing to or affected by the PSVT.
Makes sense to check the plumbing and structure.
Absolutely. And in patients who have a history of chest pain that sounds like angina or other risk factors for coronary artery disease, further screening tests like a coronary CT angiogram or a cardiac stress test might be considered to rule out any significant blockages in the heart's arteries.
So the evaluation is really comprehensive, not just about catching the rapid heart rhythm, but also about looking for any underlying heart issues or other potential triggers that might be involved. Let's move on now to the treatment of PSVT. The review talks about both how to handle an episode when it's happening, that's acute therapy, and strategies for preventing it from happening again in the future, long-term therapy.
Exactly. The goals are twofold. The primary goal of acute therapy is to terminate the current episode of rapid heart rhythm, stop it quickly, and relieve the patient's distressing symptoms. Get them feeling better fast.
Right.
In cases where the symptoms are particularly severe or the patient's condition is unstable, more immediate intervention might be needed. On the other hand, long-term therapy is focused on preventing future episodes of PSVT from occurring, or at least reducing their frequency and severity, and thereby reducing the overall burden and impact of the arrhythmia on the patient's life.
Improving quality of life.
Definitely. And as we touched on earlier, catheter ablation has emerged as a really significant advancement in this field. It offers a safe, effective, and in many cases, potentially curative treatment option for PSVT. It's a major step forward beyond just managing episodes with medication indefinitely.
Okay, let's start by talking about acute therapy. What are the first steps that are usually taken when someone is having a PSVT episode and they are medically stable, they're not about to collapse, but their heart is racing?
Right. For patients who are hemodynamically stable, meaning their blood pressure is okay, they're conscious, alert, not showing signs of severe distress like crushing chest pain or severe shortness of breath, The first-line treatment often involves trying vagal maneuvers.
Vagal maneuvers. What are those exactly?
These are simple, non-invasive physical techniques that stimulate the vagus nerve. The vagus nerve has a significant influence on the heart's electrical system, and stimulating it can, specifically, slow down the conduction of electrical signals through the AV node.
Hitting the brakes on the AV node.
Essentially, yes. And since many PSVTs rely on the AV node being part of the circuit, slowing it down can break the loop. Figure 3A in the review provides a nice overview of this approach.
We've probably all heard of the Valsalva maneuver, like bearing down. Is that the main one that's used?
The standard Valsalva maneuver involves having the patient try to exhale forcefully against a closed airway for a period of time, like trying to blow up a really resistant balloon or straining. However, a modified version of this maneuver, which was studied in a big clinical trial called the REVERT trial, has actually shown to be significantly more effective in terminating PSVT.
A modified version. How does that work?
This modified maneuver involves a specific sequence. The patient strains, usually by blowing into a manometer to maintain a pressure of about 40 millimeters of mercury for 15 seconds while they're in a semi-reclined position.
Okay, straining while semi-upright.
Right. Then, immediately after stopping the strain, they are quickly moved to lie flat on their back and their legs are passively raised by someone else to a 45-degree angle for another 15 seconds. Then they return to the semi-reclined position.
So, strain, then lie flat with legs up. Why does that work better?
The idea is that the leg elevation and lying flat part dramatically increases the return of blood to the heart during the recovery phase after straining. This enhances the stimulation of the baroreceptors' pressure sensors in the blood vessels, which further boosts the vagal response and is more effective in slowing down the heart rate and stopping the SVT.
Gives it an extra kick.
Exactly. The REVERT trial found that this modified maneuver successfully converted the heart rhythm back to normal in 43% of patients, which was significantly better than the 17% success rate they saw with the standard Valsalva maneuver.
Wow, more than double the success rate.
Yeah, and interestingly, similar success rates have been observed in another study where patients simply blew forcefully into a standard 10 milliliter syringe for 15 seconds, which presumably generates similar pressure.
Simple and effective.
And because it's safe and relatively easy to learn, there's even a video demonstration in the review. Video 1, this modified Valsalva maneuver, can even be taught to patients so they can try it themselves at home if they feel an episode starting. Gives them some control.
That's fantastic. That there's a non-drug option that patients can learn to use themselves, and that it's actually quite effective.
Yeah.
What about carotid sinus massage? That was also mentioned as a type of vagal maneuver. How is that done, and is it as good?
Carotid sinus massage, shown in video 2, involves gently applying pressure with your fingers over the carotid artery in the neck, specifically at the area where it branches, called the carotid bifurcation. There are pressure sensors there too.
Right.
This pressure is typically applied firmly but gently for about 5 seconds, usually on one side of the neck at a time, never both simultaneously.
Okay.
One clinical trial found that the effectiveness of carotid sinus massage in stopping PSVT was actually similar to that of the standard Valsalva maneuver in their study, maybe around 10-20% successful. So perhaps not as effective as the modified Valsalva.
And are there risks with that one?
Yes, it's really important to exercise caution. It should be avoided in patients who have a carotid bruit, an abnormal sound heard with a stethoscope over the artery, which can indicate narrowing, or in those with known significant carotid artery stenosis, meaning blockage. There's a very small theoretical risk of dislodging plaque from the artery wall and causing a stroke.
Ooh, okay. Definitely need to be careful there.
For that reason, it's a technique that's generally performed by a trained healthcare professional after listening to the neck first, not usually something taught to patients for self-use.
Safety first, absolutely. Yeah. Okay, so if these vagal maneuvers, either the modified Valsalva or maybe carotid massage done by a professional, don't work to stop the PSVT episode, what's usually the next step in acute therapy for a stable patient?
If vagal maneuvers are unsuccessful, the next line of treatment for a hemodynamically stable patient is typically the intravenous administration of adenosine.
Adenosine, that's a common one, right?
Very common. Adenosine is a very fast-acting medication. It works by temporarily blocking or significantly slowing the electrical conduction through the AV node.
Hitting the brakes even harder.
Much harder, but very briefly. This can effectively interrupt those reentry circuits like an AVNRT and orthodromic AVRT that rely on conduction through the AV node to keep the rapid heart rhythm going.
And it works fast.
Extremely fast. It has a very short half-life in the body, only about 10 seconds, maybe even less. So its effects are very potent, but very brief. It's typically given as a rapid intravenous bolus, usually starting with 6 milligrams, pushed quickly over just 1-2 seconds, followed immediately by a rapid flush of saline solution to help push the medication quickly through the veins to the heart before it gets broken down.
Got to get it there quick.
Exactly. A recent meta-analysis looked at whether it matters if you mix the adenosine with saline in one syringe or give it sequentially, and found similar efficacy, though based on limited data.
Okay. And you need to monitor the patient closely when giving it.
Absolutely critical. You need to have a continuous electrocardiogram, or ECG, running while adenosine is being administered, as shown nicely in Figure 3B of the review. Watching the ECG response is key.
Why is that so important?
Because the way the heart rhythm responds to adenosine, does it stop? Does it slow down and reveal underlying atrial activity? Does it not respond at all? Can often provide very valuable diagnostic clues about the specific subtype of PSVT the patient is experiencing. For example, if it stops the tachycardia, it strongly suggests the AV node was involved in the circuit.
Diagnostic as well as therapeutic.
Exactly. Additionally, it's always wise clinical practice to have defibrillation pads readily available, maybe even attached to the patient when giving adenosine, not because it's common to need them, but just as a safety precaution in case of any unexpected or rare adverse reactions, like prolonged pauses or inducing other arrhythmias.
Better safe than sorry. And are there any common side effects that patients might feel when they receive adenosine? It sounds quite dramatic.
It can feel dramatic, yes. The most commonly reported side effects are usually very brief and transient, occurring because adenosine affects receptors elsewhere in the body too. These include flushing of the face and neck, that's quite common. Maybe 60% of patients feel that warmth. Also, a sense of chest tightness or pressure and shortness of breath are fairly common, maybe around 10, 12%, and 7% respectively. Some people describe a feeling of impending doom, but it passes very quickly.
Sounds unpleasant, but short-lived.
Very short-lived, usually just for a few seconds. And overall, adenosine is considered highly effective in terminating AV node-dependent PSVT in most patients. A meta-analysis comparing it to calcium channel blockers showed a success rate of nearly 90%.
So a very common and effective first-line drug for acutely treating PSVT when vagal maneuvers don't work. Are there any specific situations where adenosine should generally be avoided or used with extra caution?
Yes, there are a few important ones. Generally, it's used with extreme caution or avoided in patients who have had a heart transplant. Their transplanted hearts are denervated, meaning the nerve supply is cut, and they can sometimes be hypersensitive to adenosine's effects, potentially leading to prolonged pauses or heart block.
Okay, transplant patients need special care.
Definitely. Although one study did suggest that using very low initial doses might be safe in younger heart transplant recipients. Another major contraindication is in patients who have atrial fibrillation and also have evidence of pre-excitation on their ECG, that WPW pattern.
The AFib plus WPW combination. Why is that bad?
Because in that situation, if you block the AV node with adenosine, you might inadvertently allow all those chaotic atrial fibrillation impulses to conduct extremely rapidly down the accessory pathway to the ventricles without any filtering. This can cause dangerously fast ventricular rates, potentially leading to ventricular fibrillation and cardiac arrest. So adenosine is a definite no-no in known WPW with AFib.
Critical point.
Also, it's important to be aware that adenosine itself can sometimes trigger an episode of atrial fibrillation in some susceptible individuals, even as it stops the SVT. And because there have been rare case reports of adenosine-inducing bronchoconstriction, it should be used with caution in patients who have a history of significant asthma or active wheezing.
Lots of important considerations when using adenosine. Okay, what about other medications that can be used acutely to treat PSVT? The review also mentioned non-dihydropyridine calcium channel blockers and beta blockers.
Yes, if adenosine isn't effective or is contraindicated, non-dihydropyridine calcium channel blockers like intravenous verapamil or diltiazem are often the next choice.
How do they work?
Similar to adenosine, they work primarily by blocking or slowing electrical conduction through the AV node. They affect the calcium channels involved in AV node cell activity. This can help to break the reentry circuits that depend on AV nodal conduction, like AVNRT and orthodromic AVRT.
And are they as effective as the adenosine?
A meta-analysis comparing them to adenosine found that their success rates in converting PSVT back to normal sinus rhythm were actually quite similar, maybe around 90–93%. They tend to work a bit slower than adenosine over minutes rather than seconds, but last longer.
Any downsides?
The main thing to watch for is a potential drop in blood pressure, hypotension, after they're given, as they can relax blood vessels too. However, the risk of clinically significant hypotension was found to be relatively low, less than 1% in the studies reviewed. But importantly, these calcium channel blockers should generally be avoided in patients who have heart failure with a reduced ejection fraction, a weak heart pump, as they can sometimes worsen heart failure symptoms due to their negative effect on heart muscle contraction.
Okay, caution in heart failure. And what about beta blockers? We often hear about beta blockers being used for various heart conditions. Do they have a big role in acutely terminating PSVT?
Well, while beta blockers certainly slow down the heart rate by blocking the effects of adrenaline on the heart and the AV node, there's generally less robust evidence to support their effectiveness in directly and rapidly terminating an ongoing episode of PSVT compared to adenosine or calcium channel blockers.
So maybe not the first choice for stopping it immediately.
Not usually for immediate termination, no. However, they can be very useful for achieving rate control, slowing down the ventricular rate if the SVT persists, and they're recommended in some guidelines as an alternative option if adenosine is ineffective or not appropriate.
Okay.
One study actually found that diltiazem, the calcium channel blocker, was more effective than the intravenous beta blocker esmolol in terminating PSVT. However, there is some evidence suggesting that the combination of a calcium channel blocker like diltiazem plus a beta blocker like propranolol might be more effective than placebo in restoring normal rhythm over a couple of hours.
Interesting combination.
Yeah. But again, it's important to remember that beta blockers, like calcium channel blockers, should generally be avoided in patients who are experiencing acute decompensated heart failure, as they can potentially worsen the situation.
Right. So calcium channel blockers and beta blockers can play a role in acute management, maybe more as second line for termination or for rate control, but with some important cautions. The review also mentioned the potential role of antiarrhythmic drugs in acute PSVT management, even though the evidence might be more limited for some.
Yes. Even though the evidence base might not be as strong or extensive as for adenosine or calcium channel blockers, certain antiarrhythmic medications can definitely be effective in acutely terminating PSVT in selected cases.
Which ones?
Class I antiarrhythmic agents, such as intravenous propafenone and oral or intravenous flecainide, work by blocking sodium channels in the heart cells. This directly affects the electrical properties of the atrial muscle, accessory pathways, and the his Purkinje system, and can help restore a normal sinus rhythm.
Do we know how well they work?
Studies have shown that intravenous propafenone can be quite effective, terminating AVNRT in maybe 76% and AVRT in about 88% of induced cases in the lab. Similarly, oral flecainide has been shown to achieve cardioversion in around 61% of patients experiencing PSVT in another study. It's interesting to note that while inhaled flecainide is being investigated for treating atrial fibrillation, there's currently no real evidence to support its use in acutely treating PSVT.
Okay. Any others?
Other antiarrhythmic drugs like intravenous abutolide, Galton's 3 agent, and amiodarone, which has multiple class effects, can also be used, particularly for certain types of SVT like AVRT or focal atrial tachycardia, although they may not work as rapidly as adenosine. Ibutolide was shown effective in about 39% of focal AT episodes in one study. In more challenging refractory cases that haven't responded to other things, intravenous procainamide, a class CA agent, might also be considered.
So quite a few options there. Is there a preference for certain drugs in specific SVT types?
Yes, particularly in cases of antidromic AVRT, remember? That's the one with the wide QRS complex, where the impulse goes down the accessory pathway. First, antiarrhythmic medications that directly affect the accessory pathway, like procainamide or sometimes abutolide, are generally preferred over AV nodal blocking agents like adenosine or calcium channel blockers. Blocking the AV node in that situation doesn't help and could be harmful if underlying AFib is present.
Right. Need to target the right part of the circuit.
Exactly. And a crucial point with all antiarrhythmic drugs is that they have the potential for proarrhythmic effects, meaning they could paradoxically trigger other, sometimes more dangerous, abnormal heart rhythms. Because of this, careful patient selection, often inpatient monitoring when starting them, and close outpatient follow-up with ECG monitoring are usually recommended when these medications are used.
Important safety considerations. So There's a range of drug options available for acute treatment, depending on the specific circumstances, the type of PSVT, the patient's stability, and their overall health. What about in situations where someone is having a PSVT episode and they are hemodynamically unstable, really showing signs of severe distress? What's the approach then?
In patients who are hemodynamically unstable, showing signs like very low blood pressure, severe ongoing chest pain suggesting ischemia, significant shortness of breath with pulmonary edema, or altered mental status due to poor brain perfusion, the treatment of choice is immediate, emergent, synchronized, direct current cardioversion.
An electrical shock.
Yes. This involves delivering a controlled electrical shock to the chest, synchronized with the heart's own rhythm, the R wave, to try and immediately reset the heart's entire electrical activity and restore a normal sinus rhythm. It's the fastest and most effective way to deal with an unstable tachycardia.
And it works well.
Highly effective. Studies have shown success rates approaching 100% for terminating unstable SVT, even when performed by paramedics in the out-of-hospital setting.
Wow. Does it hurt?
If the patient is conscious, yes, it's uncomfortable. So for patients who are relatively stable but still require cardioversion, or even unstable but conscious, sedation is typically necessary before the electrical shock is administered to minimize discomfort and anxiety. The typical initial energy settings for synchronized cardioversion of SVT are usually relatively low, often starting between 50 and 100 joules.
Okay, so instability means electricity, usually with sedation if possible. That covers how to handle an episode when it's actually happening. Now let's talk about the really important part for many patients, preventing PSVT from coming back. The review really seemed to emphasize the role of catheter ablation for this long-term prevention.
Yes, absolutely. The medical evidence accumulated over the last couple of decades strongly supports catheter ablation as a safe, generally cost-effective, and often curative intervention for patients who experience recurrent symptomatic episodes of PSVT.
Curative, meaning it can fix the problem for good.
In many, many cases, yes. Because of its high success rates and the potential to permanently eliminate the underlying cause of the arrhythmia, catheter ablation is increasingly being considered and recommended in guidelines as a first-line therapy for many individuals with recurrent symptomatic PSVT, rather than just being reserved as a last resort after years of medications have failed.
So maybe offered earlier in the treatment course now?
Definitely considered earlier. The procedure itself is typically performed percutaneously.
Meaning through the skin?
Yes, through small punctures in the skin, usually in the groin area where the large femoral veins are. Thin, flexible tubes, called catheters, which have electrodes on their tips, are then carefully guided through the blood vessels up into the different chambers of the heart under X-ray guidance, or sometimes using non-fluoroscopic mapping systems.
Like navigating wires inside the heart.
Exactly. Once inside the heart, sophisticated electrical mapping techniques are used. These allow the electrophysiologist to pinpoint the exact location of the abnormal electrical pathways or the misfiring focus that's causing the tachycardia.
Finding the trouble spot.
Precisely. Then, once the critical target site is identified, energy is delivered through the tip of a specialized ablation catheter to destroy or ablate that very small specific area of heart tissue. This energy is most commonly in the form of radiofrequency energy, which generates heat.
Okay, heat ablation.
Or sometimes cryoenergy, which uses extreme cold to freeze the tissue. Both methods create a tiny scar that blocks the abnormal electrical conduction.
Freezing or heating to create a roadblock.
You got it. This effectively interrupts the abnormal electrical circuit or silences the abnormal focus, preventing the PSVT from recurring. In most cases, a detailed electrophysiology study, or EPS, is performed as part of the same procedure right before the ablation to precisely confirm the type of arrhythmia and map out the optimal target sites for ablation.
So you diagnose and treat in the same session often?
Very often, yes. Because this is a specialized procedure requiring specific expertise and equipment, the general recommendation is that patients should be referred to an electrophysiologist, a cardiologist who specializes in heart rhythm disorders after they have been diagnosed with PSVT and received initial acute management, to discuss the potential benefits and risks of catheter ablation as a long-term treatment strategy tailored to them.
Makes sense to see a specialist for that. So it's a targeted procedure to essentially fix the electrical short circuit or abnormal firing in the heart that's causing the PSVT. And the success rates for these procedures sound really high, especially for the most common types like AVNRT and AVRT.
They are indeed very encouraging, representing a major advance in cardiology. For AVNRT, the most common type, a large meta-analysis pooling data from multiple studies showed a single procedure success rate of over 94%. That's eliminating the arrhythmia with one procedure.
Over a 94%. That's amazing.
It really is. Furthermore, a randomized controlled trial directly compared catheter ablation to long-term medical therapy using common drugs like beta blockers or diltiazem for preventing AVNRT recurrences. The results were quite striking. Over a 5-year follow-up period, the ablation group experienced virtually no recurrences of PSVT 0% in that study compared to a 68% recurrence rate in the group just taking medication.
0 versus 68%. That's a huge difference.
Massive difference. And it's also important to note that AVNRT ablation has been shown to be both effective and safe even in older patients, including those over the age of 75 who might have other health issues. Age itself isn't necessarily a barrier.
Good to know. What about for AVRT, the one with the accessory pathway? Is ablation just as good there?
Yes, for symptomatic AVRT that involves an accessory pathway, catheter ablation aimed at eliminating that extra pathway is also considered the first-line preventive therapy. Longitudinal studies following patients over time have reported very high acute success rates for ablating accessory pathways, often around 98.5%.
Also incredibly high. Any risks?
The main potential risk specific to AVR accessory pathway ablation is the risk of inadvertently damaging the normal AV node or his Purkinje system during the ablation, which could lead to AV block requiring a permanent pacemaker. However, this risk is generally quite low, estimated to be around 0.3% in experienced centers.
So very successful with a small risk of needing a pacemaker. What about those more challenging accessory pathways that you mentioned might be located in the septum, the wall between the heart's chambers? Are they harder to ablate successfully?
Yes, ablation of accessory pathways located in the septal region of the heart can sometimes be more technically challenging. This is mainly due to their close proximity to the normal AV node and the his Purkinje conduction system. You have to be very precise to ablate the pathway without injuring the normal structures.
Less room for error.
Exactly. A meta-analysis that specifically looked at the outcomes of ablating these tricky septal accessory pathways did show a slightly higher recurrence risk compared to pathways located elsewhere, like on the free wall of the heart. For radiofrequency ablation of septal pathways, the recurrence rate was around 11.6% over an average follow-up of about 3 years. For cryoablation, which might be used preferentially near the AV node because it's thought to be safer, the recurrence rate was a bit higher, about 24.1%, but over a shorter average follow-up of just over a year.
So still often successful, but maybe a bit trickier, and with a slightly higher chance of the pathway recovering over time compared to easier locations.
That seems to be the case, yes. Requires particular expertise.
And the review mentioned something interesting. Even in people who have the WPW pattern on their ECG but haven't actually experienced any symptoms of PSVT yet, ablation might still be beneficial in some cases. That sounds like a very proactive approach.
It is proactive, yes. There's growing evidence suggesting that individuals who have asymptomatic pre-excitation, meaning they have the WPW pattern on their baseline ECG, but no documented history of symptomatic tachycardia, particularly those who are identified through testing as being at higher risk for developing dangerous arrhythmias in the future, might benefit from undergoing prophylactic catheter ablation of the accessory pathway.
Preventing a problem before it happens.
Exactly. One important study specifically looked at this in patients deemed high risk based on non-invasive testing or findings during an EP study. They found a significantly lower rate of future arrhythmic events, including sudden cardiac death or the need for resuscitation in the group that underwent preventive ablation compared to the control group who were just monitored over a 5-year follow-up period. It was a dramatic difference, like 7% versus 77%.
Wow. So identifying those high-risk asymptomatic individuals is key.
It is. This proactive approach is often strongly considered, or even required, for individuals in certain high-risk professions where sudden incapacitation would be disastrous, like airline pilots or commercial truck drivers, or for those who participate in high-intensity competitive sports.
So in some specific situations, it might be much better to fix the wiring even before it causes obvious problems, especially if there's an identified elevated risk. What about preventing recurrences of focal atrial tachycardia with catheter ablation? Is that also a recommended approach?
Yes, catheter ablation is definitely recommended as a primary strategy for preventing recurrent symptomatic focal atrial tachycardia. The goal here is to find that single misfiring spot, that focus in the atrium, and eliminate it.
And how successful is that?
Studies have shown good immediate success rates in identifying and ablating the specific focus, often around 77% in the initial procedure. And importantly, many patients remain free from recurrence of AT over the long term after a successful ablation. One study reported a 90% freedom from recurrence after successful ablation over an average follow-up of almost 3 years.
That's great long-term relief.
Yes. Another study that specifically looked at ablating focal AT originating near the pulmonary veins reported a 96% freedom from AT after an average of about 2 years. And remember that retrospective analysis we mentioned earlier?
The one about cardiomyopathy.
Exactly. Patients who develop tachycardia-mediated cardiomyopathy, that weakening of the heart muscle due to the persistently fast heart rate from focal AT, found that successful ablation of the atrial tachycardia led to a normalization or significant improvement of their ejection fraction, their heart pump function, in 97% of cases.
That's incredible. Fixing the electrical problem can actually allow the heart muscle to recover and heal itself. That really underscores the benefit of ablation in those cases. So ablation seems to be a very effective, often curative option for preventing recurrent PSVT across the different common subtypes. But what about people who either can't undergo ablation, maybe due to other health reasons, or perhaps they simply don't want to have an invasive procedure? What are the pharmacologic or medication-based options for long-term prevention of these episodes?
Right. Medication remains an important option. However, it's fair to say that the medical evidence for the long-term effectiveness of medications in preventing PSVT recurrences is generally considered to be more limited compared to the very high success rates achieved with catheter ablation. Medications are often more about suppression than cure.
Okay, managing versus eliminating.
Kind of, yeah.
Yeah.
But there are still a number of medications that can be used to help reduce the frequency and severity of PSVT recurrences. Current clinical practice guidelines, as summarized in the reviews table, often recommend beta blockers like metoprolol, propranolol, or non-dihydropyridine calcium channel blockers like diltiazem or verapamil as first-line pharmacologic agents for long-term prevention of PSVT.
The same ones used sometimes acutely.
Often, yes, but taken regularly as a daily dose to prevent episodes. If those aren't effective enough or aren't well tolerated by the patient due to side effects, then class-site antiarrhythmic medications like flecainide and propafenone are typically considered as second-line options. For patients who experience only infrequent but still bothersome recurrences of PSVT, a pill-in-the-pocket approach might be considered.
Pill in the pocket. What's that?
This involves the patient carrying a dose of a medication. It could be flecainide, propafenone, or sometimes even diltiazem, verapamil, or a beta blocker, and taking that single dose only when they feel an episode of PSVT starting to try and terminate it themselves, rather than taking a daily preventive medication. It requires careful patient selection and education.
Treating it themselves as needed if the episodes are rare.
Exactly. Another option for prevention is dofetilide, which is a class 3 antiarrhythmic. However, starting dofetilide requires an initial 72-hour period of hospitalization with continuous ECG monitoring because of the risk of a potentially dangerous heart rhythm abnormality called torsades de pointes related to QT prolongation, so it's less convenient to initiate.
Right, needs close monitoring at the start.
Then there's amiodarone. It's a very potent antiarrhythmic drug with effects across multiple classes, and it can be considered for preventing refractory cases of PSVT that haven't responded well to other therapies. However, long-term use of amiodarone carries potential risks of significant side effects affecting the lungs, liver, thyroid gland, skin, and eyes, so it's usually reserved for more challenging situations where benefits outweigh those risks.
Lots of potential baggage with amiodarone.
It does require careful monitoring, yes. Finally, there's some emerging evidence suggesting that ivabradine, a medication that specifically slows down the heart rate by acting on the SA node's funny current, might be a potential adjunctive therapy, meaning used in addition to beta blockers, in preventing the recurrence of atrial tachycardia in some patients. Still more research needed there.
So medications can certainly play a role in managing PSVT long-term, helping to reduce recurrences. But it sounds like often ablation offers a more definitive and potentially curative solution if the patient is suitable and willing. What's the overall outlook or prognosis for someone who has PSVT? Is it generally considered dangerous?
In general, the prognosis for patients with PSVT, especially the common forms like AVNRT and AVRT, who do not have significant underlying structural heart disease, is quite good, particularly now with the availability of highly effective treatments like catheter ablation. It's usually not life-threatening in itself in an otherwise healthy heart.
That's reassuring.
However, it can certainly impact quality of life. And even with pharmacologic therapy alone, many individuals may continue to experience breakthrough symptoms, perhaps 50% still having monthly symptoms in some studies.
So medication doesn't always eliminate symptoms completely?
Often not. Now, some retrospective studies have shown a small but real risk, maybe around 1.2% over about 3 years in one study, of developing heart failure or cardiomyopathy over time in patients with AVNRT or AVRT, particularly if the episodes are frequent or prolonged. Older age and the presence of pre-existing heart disease were identified as independent predictors of these adverse events.
So the fast heart rate itself can weaken the heart over time in some people.
It seems it can in a subset of patients, yes, leading to that tachycardia-mediated cardiomyopathy we discussed. But the good news, again, is that in those cases caused by a rapid atrial rhythm like focal AT, or sometimes even incessant AVNRT, AVRT, successful ablation can often lead to a significant, sometimes complete, restoration of the left ventricular systolic function. The heart's ability to pump blood effectively recovers. Remember that 97% normalization rate after focal AT ablation.
Right, the heart can bounce back if you fix the rhythm.
Often, yes. Interestingly, one large study that looked at a massive claims database found that having a diagnosis of PSVT was independently associated with a slightly increased risk of stroke later on. The absolute risk increase was relatively small, maybe around 1%, but the association was statistically significant.
Stroke. That seems unexpected. Do we know why?
The exact mechanism behind this association isn't entirely clear yet and needs further investigation. It might be related to transient blood clot formation during the episodes, or perhaps PSVT is sometimes a marker for other underlying vascular issues, or maybe sometimes atrial fibrillation gets misdiagnosed as PSVT initially. More research is needed there.
Okay.
And one final point on prognosis and potential complications. In patients who have implantable cardioverter defibrillators, or ICDs, implanted for other reasons, like preventing sudden death from ventricular arrhythmias, PSVT can sometimes be misclassified by the device. The ICD might mistake the rapid PSVT for a more dangerous ventricular tachyarrhythmia.
And deliver an unnecessary shock. Ouch!
Exactly, potentially leading to inappropriate and painful shocks. However, this risk can often be significantly mitigated by using sophisticated detection algorithms in the ICD, particularly those that use information from both the atrium and the ventricle, Bill chamber detection, to better discriminate between SVT and VT.
Good to know that the technology can help avoid those false alarms. So the overall outlook is generally positive, especially with effective treatments like ablation now available, but there are some potential long-term issues like cardiomyopathy or maybe stroke risk to be aware of, and device interactions. Now, let's touch briefly on some practical considerations in specific populations mentioned in the review. What about PSVT in children? We mentioned it can occur even in infants.
Yes, in the pediatric population, PSVT is actually most commonly diagnosed in newborns and young infants.
Really, right from the start.
Often, yes. And in this very young age group, AVRT, the type involving an accessory pathway, is the most frequent mechanism found. This is thought to be partly due to the presence of accessory pathways that are sometimes associated with the normal immaturity of the heart's electrical conduction system at that early stage of development. Some pathways may disappear on their own later. There's also a relatively rare but sometimes notoriously difficult to control form of orthodromic AVRT seen specifically in infants called permanent junctional reciprocating tachycardia, or PJRT. It tends to be incessant or nearly continuous.
That sounds challenging. Does PSVT diagnosed in infancy usually stick around?
Interestingly, no. PSVT that is diagnosed in infancy often resolves spontaneously without any specific treatment in the vast majority of cases. Estimates are around 90% by age 1.
Oh, they just grow out of it.
Many do. However, recurrence can certainly happen later in childhood or adolescence. In contrast, AVNRT, the type involving the slow and fast pathways within the AV node, is more typically diagnosed in older children and adolescents rather than infants.
Okay, different types common at different ages in kids. And how might PSVT present or be recognized in babies and young children who can't exactly say, "my heart is racing"?
That's the challenge. The symptoms and signs of PSVT in infants and young children can be quite different from what adults typically report. They're often nonspecific. In young infants, you might observe things like unexplained irritability, fussiness.
It's a cranky baby.
Could be, but also poor feeding and failure to thrive, not gaining weight properly, sometimes vomiting or other gastrointestinal symptoms, and sometimes parents might actually notice their baby's chest moving very rapidly or feel their heart racing when holding them. Palpitations can sometimes be reported by older children.
So subtle signs mostly in infants. How is it treated acutely in kids?
For acute treatment in pediatric patients, vagal maneuvers can be attempted in older, cooperative children. Sometimes things like putting an ice pack briefly on their face can work in infants. Adenosine is often the first-line medication used, just like in adults, adjusted for weight, to try and terminate the tachycardia.
Okay.
If adenosine doesn't work or isn't appropriate, class IK antiarrhythmic medications like flecainide or propafenone can also be used intravenously. And just like in adults, in cases of hemodynamic instability, emergent electrical cardioversion is necessary.
And for long-term prevention or suppression in kids?
Various pharmacologic therapies might be used, again, depending on the specific situation, the type of SVT, the child's age, and their overall health. Common options include beta blockers like propranolol, sometimes digoxin, though used less now, classic agents, amiodarone in difficult cases, and sotalol, which is both beta blocker and class 3 effects.
What about catheter ablation for treating PSVT in children? Is that also an option, or are there different considerations because they're smaller?
Yes, catheter ablation has become an increasingly important and highly effective part of the long-term management of PSVT in children of all ages, even infants in specialized centers. Studies have shown very high overall acute success rates with radiofrequency ablation for various types of SVT in the pediatric population, often around 97–98%, similar to adults.
That's great, but are there unique challenges?
Yes, there are some specific considerations. In very young children, particularly those under the age of 5 or weighing less than 15 kilograms, medication might sometimes be preferred as the initial long-term treatment strategy. This is partly due to the smaller size of their hearts and blood vessels, which can make catheter manipulation potentially more challenging and carry slightly higher risks.
Size matters.
It can. Also, cryoablation using cold is often favored over radiofrequency ablation, heat, in the pediatric population, especially for pathways near the AV node. This is because cryoablation is thought to have a lower risk of causing permanent damage to the normal conduction system, specifically complete AV block requiring a pacemaker, which is a complication you really want to avoid in a child.
Safer near critical structures.
That's the idea. Studies using cryoablation for AV-NRT in adolescents have shown excellent immediate success rates, although the recurrence rate might be slightly higher than RF over time. But even if a recurrence does occur, repeat ablation is often successful in achieving long-term cure.
So while there are some different considerations for children, effective treatments like catheter ablation are definitely available and can be very successful, with cryoablation often preferred. What about PSVT in women who are pregnant? Does pregnancy change things? Are there any unique challenges or management strategies in that situation?
Yes, pregnancy definitely adds complexity. Firstly, pregnancy itself seems to increase the risk of developing SVT or having more frequent episodes if you already have it. The estimated incidence is around 22 cases per 100,000 pregnancies.
Why does pregnancy increase the risk? Hormones,
Well,
blood volume changes.
likely a combination of factors, hormonal changes, increased blood volume leading to cardiac stretch, changes in autonomic tone. Pregnancy is also associated with an increased risk of severe maternal complications if SVT occurs, including heart failure and shock, and also a higher likelihood of needing a cesarean delivery.
Okay, so potentially more serious during pregnancy. How is it managed? Are the drugs safe?
That's the main challenge. There's often limited high-quality data available on the efficacy and, more importantly, the safety of many antiarrhythmic drugs during pregnancy, as these medications can potentially cross the placenta and affect the developing fetus.
Right, you have to consider the baby too.
Absolutely. As a general principle, antiarrhythmic drugs are avoided, if at all possible, during the first trimester of pregnancy, which is the critical period for organ development, due to concerns about potential teratogenic effects or birth defects.
Okay, avoid drugs early on if you can. What about later in pregnancy or for prevention throughout?
For long-term preventive therapy during pregnancy, if needed, beta blockers are often considered the first-line agents. Specifically, propranolol and metoprolol are commonly used. Atenolol, another beta blocker, is generally avoided due to some evidence linking it to potential fetal growth restriction.
Okay, some beta blockers preferred over others. What if they don't work?
Second-line therapies might include digoxin or the calcium channel blocker verapamil. In specific situations like WPW syndrome with frequent SVT or perhaps incessant atrial tachycardia that's not responding to beta blockers and calcium channel blockers, class IK agents like flecainide or propafenone might be considered, but it requires carefully weighing the potential benefits against the fetal risks. Sotalol is another option sometimes used.
What about amiodarone?
Amiodarone is usually reserved for only the most refractory, life-threatening arrhythmias during pregnancy because it carries a known risk of causing fetal hypothyroidism and other potential issues. And another antiarrhythmic called dronedarone is strictly contraindicated in pregnancy.
So limited drug options need careful choices. What about ablation during pregnancy?
Catheter ablation is generally avoided during pregnancy whenever possible. The main concern is fetal exposure to radiation from the fluoroscopy, the X-ray guidance typically used.
Right, radiation and the fetus don't mix well.
Exactly. However, in situations where SVT is refractory to medications and causing severe symptoms or hemodynamic instability, ablation can be performed during pregnancy, but it should be done at experienced centers. Ideally, they would use techniques to minimize radiation exposure, such as using non-fluoroscopic mapping systems like electroanatomic mapping as much as possible.
So possible in emergencies, but try to avoid it.
Yes. And the strong recommendation is that for women with known problematic PSVT who are planning to become pregnant, they should strongly consider undergoing elective catheter ablation prior to conception if they are eligible. Fix the problem before getting pregnant.
That makes a lot of sense. Plan ahead. Okay, one last special group. What about exercise and PSVT? Can physical activity trigger episodes, and how does it affect athletes?
Yes, in some individuals, PSVT episodes can definitely be triggered by physical activity, sometimes predictably during or shortly after intense exertion.
Exercise-induced PSVT.
Exactly. For anyone who experiences exercise-associated PSVT, it's generally recommended that they undergo an evaluation, including an echocardiogram, to look for any underlying structural heart disease that might be contributing.
Rule out other heart issues first.
Right. Now, for athletes who are diagnosed with Wolff-Parkinson-White, WPW syndrome, catheter ablation of the accessory pathway is often strongly recommended, sometimes even required for participation clearance in certain sports. This is because of that heightened risk of sudden cardiac arrest that can occur during intense exercise in this specific population if they develop AFib.
Okay, WPW in athletes often means ablation. What if they just have the pattern but no symptoms?
For individuals who have the asymptomatic WPW pattern on their ECG, risk stratification is usually performed. This might involve a stress ECG looking to see if the pre-excitation pattern disappears abruptly with high heart rates, which suggests the pathway is lower risk, and sometimes an invasive electrophysiology study is recommended to directly measure the pathway's properties, especially if they are professional or high-level competitive athletes.
Checking how risky the pathway is.
Exactly. Catheter ablation can also be considered for other forms of PSVT in the context of exercise, such as AV-NRT, concealed EVRT, where the WPW pattern isn't obvious on the baseline ECG, or focal atrial tachycardia, particularly if the episodes are frequent, symptomatic during activity, or significantly interfere with their athletic training or performance.
So ablation is often an option to keep athletes competing safely.
Yes. According to the 2020 European Society of Cardiology, ESC guidelines on sports cardiology, patients with a history of PSVT without ventricular pre-excitation, so no WPW pattern, can generally participate in all sports. That's a Class A recommendation.
Good news for many. What about medications in athletes?
Pharmacologic therapy with daily preventive medications like beta blockers or sodium channel blockers, Class A, is generally avoided in athletes if possible. This is partly because these medications can sometimes have negative effects on maximal athletic performance. Beta blockers especially can limit peak heart rate.
Right, might slow them down.
Plus, beta blockers are actually prohibited by the World Anti-Doping Agency, WAD, in certain precision sports like archery or shooting, as they can reduce tremor. So ablation is often preferred in athletes to avoid medication issues.
Okay, and you mentioned certain jobs.
Yes, it's also worth noting that for individuals in certain occupations where a sudden episode of PSVT causing incapacitation could have serious public safety consequences, think airline pilots, commercial drivers, military personnel, catheter ablation to definitively treat the PSVT may actually be mandatory for them to maintain their occupational certification.
So exercise could be a trigger. And managing PSVT in athletes or certain professionals often involves careful risk assessment and frequently favors ablation. Finally, just to be complete, the review itself mentioned a few limitations to keep in mind about its own scope.
Yes, and it's good practice for reviews to do that. The authors noted that although they aim to be comprehensive in searching the literature, there's always a possibility that they may have missed some relevant publications. Also, they stated they did not perform a formal, systematic quality assessment of all the individual articles that were included in their narrative review.
Okay.
Additionally, it's important to clarify that this was a comprehensive narrative review, synthesizing the literature, but it wasn't conducted using the strict methodology of a formal systematic review and meta-analysis, which have more rigorous protocols for study selection and data extraction.
Different type of review.
Right. And lastly, the review specifically mentioned that it did not systematically cover the management of SVTs in the growing population of patients with congenital heart disease. SVTs are known to be quite common in adults who were born with complex heart defects, and managing them often requires very specialized approaches, likely warranting its own dedicated review in the future.
So while this review provides a very thorough and valuable overview of the common types of PSVT, it's important to remember the context and that there are always ongoing efforts to further understand and manage PSVT, especially in specific or complex patient populations.
Absolutely, the field is always evolving.
Well, that was a truly fantastic and really in-depth exploration into paroxysmal supraventricular tachycardia.
Indeed. It's a condition that, while generally benign in the absence of other heart disease and affecting both adults and children, can certainly have a significant impact on an individual's quality of life, causing fear and limiting activities.
Absolutely. And it's really encouraging to hear and important for listeners to know that catheter ablation really stands out now as a highly effective therapy for preventing those recurrent episodes, often offering a very high chance of a lasting curative solution for many people.
That's right. It's been a game changer for treating PSVT. And while ablation is such a powerful and often curative option, we shouldn't forget that pharmacotherapy, medication, still remains a vital component. It's crucial in the immediate management of acute PSVT episodes, and also plays a role in longer-term strategies to help keep the heart in a normal, healthy rhythm for those who aren't candidates for, or choose not to have, ablation.
Right. Both have their place. Now, to leave our listeners with something to think about,
Yeah.
consider this. Our understanding of the heart's incredibly intricate electrical system is constantly being refined, isn't it?
Constantly.
As technology continues to advance at such a rapid pace, we talked about AI-powered diagnostic tools that might detect subtle clues on an ECG, and increasingly precise and less invasive ablation techniques using new energy sources or better mapping. How might our ability to detect, treat, and perhaps even predict conditions like PSVT transform in the coming years?
Could we be moving towards a future where cardiac care shifts, maybe slowly, from primarily reacting to these acute episodes after they happen, towards proactively identifying those at risk and preventing them from occurring in the first place? It's certainly a fascinating prospect to think about, isn't it?